everyone. Welcome you all on behalf of RCC JIPMAR, Puducherry to Target Volume Delineation 2021 webinar series. Today's session will be conducted by Dr. Nodal and it will be on gastric carcinoma, Neoadjuvant and Adjuvant Target Volume Delineation. Sir is consultant radiation oncologist, Indraprastha Apollo Hospitals, New Delhi. He did his specialty training in radiation oncology in Medical College Hospital, Kolkata. Upon graduation, he has worked as senior resident and senior research associate in some of the leading radiation oncology centers in India, including AIMS, New Delhi, TMH, and SGPJ, Lucknow. And Sir also has did his UICC fellowship in precision radiation oncology and proton beam therapy at Cancer Institute of New Jersey, Robert Wood Johnson University Hospital, USA. His areas of interest include breast, gynecological malignancies, GI, GU, head and neck, and brain. And now it's my pleasure to invite Dr. Nodal sir to present this session on gastric carcinoma. Welcome you, sir.
Thank you so much for this invitation and this kind introduction. Can I start sharing my screen?
Yes, sir.
Okay, so am I audible and is this visible?
Yes, sir. Visible. Audible, sir.
Okay. Thank you so much. So good evening, everyone. To be part of this excellent program. I remember last year also this was quite and it's a very well coordinated, structured program. So today I am supposed to discuss about contouring part or delineation part of stomach and the flow of discussion will be something like this, and it's I have nothing to disclose. It's very difficult to teach the entire delineation aspect of stomach and adjuvant because
sorry, sir. Actually, your voice is breaking.
Cancers. Okay, might be some network issues. May I request to stop all the videos, please? Okay, so gastric cancer is one of the most difficult cancers, particularly when it comes to radiation aspect. So the tumor is variable, location is variable, presentation is different, and because of presence of a lot of very sensitive, radio-sensitive structures in and around the stomach, it becomes very difficult to plan a successful radiation for stomach cancer. And often the volume becomes very large, owing to the location and drainage pattern of stomach. So this is how the esophagus and the stomach and early part of duodenum looks like. The cardia and or the esophagogastric junction, the proximal part of stomach or cardia, the front and the body, the main part, and the antral part or distal part. And if you see the majority of the cancers of stomach are in distal part nowadays, followed by the proximal part and then body. So, and the distribution is somewhere around 40, 35, and 25, making it almost 100%. Now, the typical Sievert's classification for G-junction tumors or proximal stomach cancers, the columnar junction, and in and around that we can have 3 different types of gastric of tumors. The one within 1 and 2 centimeter of the junction is type 2, and beyond that up to 5 centimeter, that is type 1, and beyond this line for another 5 centimeter up to 5 centimeter is type 3. And that is how classically the stomach is divided into upper third, middle third, and distal third. Before embarking on delineating for stomach cancer, it is very important to understand the stomach anatomy, its relationship, its peritoneal relationships, how the lesser omentum and greater omentum are oriented, what are the structures in and around stomach, how the stomach bed is formed, on which the stomach lies upon, on superiorly, laterally, medially, inferiorly, posteriorly. So that will give a clue about how to contour the stomach bed when you are actually contouring in an adjuvant setting. It's easier to contour in a neoadjuvant setting because the intact stomach is there and you can very well appreciate the entire stomach anatomy. It becomes very difficult in adjuvant setting because the stomach is no more there and you have to interpolate all the data from preoperative imaging. So it becomes very important to realize what are the structures in and around the stomach, what are its relationships. And for the lymph nodal contouring part, it's very, very important to understand the vascular supply of stomach and the main blood vessels in and around stomach, because the lymph node stations are actually named upon or based upon the drainage pattern which are associated with blood vessels. So just for an easy summing up, these are the main structures which are in relation to stomach. So starting from above, it's like diaphragm, then going to left, it is spleen, left adrenal gland, superior portion of the left kidney, and ventral portion of the pancreas, transverse colon anterior to stomach, then vertebral body, and lesser and greater omentum on both sides of the stomach. So this is one of the very important diagram where the schematically how the blood vessels look like in and around stomach is depicted. If you remember from my last year's talk where I spoke about the blood supply or vascular contouring or vessels contouring for abdomen pelvis, we can well remember the celiac artery and its branches. Now that is the main artery and its different tributaries which actually supply the stomach. And based on this, the different lymph node stations are named. Now that is how it is divided. It gives a main 3 branches. I'll discuss this gradually. So the left gastric, the splenic, and common hepatic. Again, they are divided. The left gastric is supplying the cardia and the proximal part of the lesser curvature. And the splenic artery is again divided almost at the around the greater curvature in short gastric and gastroepiploic arteries. The common hepatic, again, it's a bit difficult. It divides into a hepatic artery proper and gastroduodenal artery. The hepatic artery proper gives a tweak, the first tweak, which is the right gastric artery. So here we get the left gastric, and here we get the right gastric. And the hepatic artery proper then again continues, and it gives 3 different branches. The rightmost is the cystic, then the right branch of hepatic artery, and left branch of hepatic artery. Now this gastroduodenal artery, it again divides into right gastroepiploic, which forms an anastomosis with the left gastroepiploic artery, which is a branch of splenic artery. And again, it divides into superior pancreaticoduodenal artery. Now, this has to be remembered very well, why that you will gradually see in this presentation. So this was the older lymph node classification by the Japanese group, where the lymph node stations were divided into 16 groups, which were based upon like this arterial divisions. The first and second group there on right and left pericardiac group. Then group 3, which is around the lesser curvature. Group 4, which was around the greater curvature. Again, this group 4 was divided into short gastric and right gastroepiploic. And then group 5, which is supraduodenal. Group 6, which is infraduodenal. 7 is left gastric, which is coming from the celiac artery. Celiac artery or celiac axis itself was level 9. Then distally it comes to splenic hilum, where it is station 10. Then the splenic artery itself, which was divided into proximal and distal part. So that was divided into arbitrary, like 50% of proximal part is 11 proximal 11P, and the latter half is distal or 11D. Then comes the hilar group, which is almost like inside the lesser omentum or the gastrohepatic ligament, where you will find this bile duct, vein, and the artery. The station 3 was retropancreatic, and to contour these retropancreatic groups, you need to actually contour the entire head of pancreas. Then comes the group or station 14, which was around superior mesenteric artery and superior mesenteric vein, is way below this. And 16 was para-aortic. However, in 2011, they have published a new English version, which is the third edition of their new classification system, where there are some modification in the pre-existing groups, and there are addition of multiple other groups, 17, 18, 19, 20, and then mediastinal groups, 110, 11, and 12. Also, they have divided the lymph nodes into 3 different tiers. The first, which is like perigastric. If you see the few lymph nodes, they're very close to the stomach. They are perigastric. Also, when the D1, D2, and D3 dissection happens, that is how they form the group of D1 lymph node dissection. Then a little bit far away from the perigastric nodes, which are in and around this, and you go here, which is basically second tier, or 7, 8, 9, and 11. So I told you that 7 is here, then 8, 9 is celiac, and 11 is around the splenic artery. And then it's either second or third or metastatic group based on where the primary tumor is. So a group of lymph node can be metastatic based upon the location of the primary tumor. Now, so it's a very exhaustive classification system, and it will not be possible to discuss each and every stations of lymph nodes here. I will request you to go through this new classification system and also follow the diagram. And you must remember this vascular supply. Now, that is how the tiers of lymph nodes are classified. The first is station 1 to 6, second is 7, 8, 9, and 11, and third is 10 to 20, and then 110, 11, and 12. Now, that is how the different types of lymph node dissections are in case of subtotal and total gastrectomy. So D1 is number 1 to 7, then D1 plus, which is D1 and 8A, 9, and 11P. Now let us go back to what is 8, what is 9, and what is 11. So 8 is anterior superior lymph node along the common hepatic artery. So if you remember, so this is the celiac trunk. It gives the common hepatic artery branch. So here it is station 8. Then 9 is the celiac artery itself, and 11 is proximal and distal pancreas, as I told you. So if you just think about this, this is the pancreatic group. So proximal half from its origin, that will be 11P, and then it will be 11D. Now, in case of D2, it's D1 and then 8A, 9, 10, 11P, 11D, and 12A. So we need to know what is 10. So 10 is splenic hilar. So earlier we were discussing about the proximal and distal splenic group, and now we come to the splenic hilum region. So here. And in case of distal gastrectomy or subtotal gastrectomy, the D1 includes number 1, 3, 4, 5, 6, and 7. D1 plus includes D1 and again again 8A and 9. If you see here, this 11P is not coming in D1 plus when it is a distal gastrectomy. D2 is D1 and then 8A, 9, 11P, and 12A. However, it does not include this 11D when it comes to distal gastrectomy. D3 is D2 and then resection of para-aortic group, which is 16A2 and B1. And D4 is D2 plus 16A1, A2, B1, and B2, and that is how the para-aortic groups are divided. Now let us go back again. What does it mean by 16, what does it mean by 110, 11, and 12? So 16 is basically the entire para-aortic group. It's divided into 16A1, A2, B1, and B2. Let me show you how this 16A1 looks like. So this is 16A1. If you remember the hiatus of esophagus, or through which the esophagus is entering, 16A1 is located there. So the hiatus, the esophagus comes down here, and that is where the para-aortic lymph node in and around the diaphragmatic opening. 16A2 is a para-aortic lymph node group. So here you can find the 16A2. It lies in between 16A1 and splenic and the left renal vein. Okay, so somewhere is between this, you can see origin of celiac artery. This is 9, and this is 16A2. So 16A2 is para-aortic lymph node between the upper margin of origin of celiac artery and lower border of left renal vein. Now coming down, this is 16B1 and 16B2. So 16B1 is para-aortic lymph node between the lower border of left renal vein. So this is the left renal vein, below this, and the origin of inferior mesenteric artery. You go down from here till the bifurcation of the aortic artery, bifurcation of the aorta, that's the 16B2. So 16A1, 16A2, 16B1, and 16B2, that is how the D4 dissection happens. Now, just a minute. Okay, so whenever we want to contour or want to delineate the structure, it's very important to know the pattern of spread. And for stomach, the pattern of spread includes definitely 3 different patterns. It's local extension, regional lymph nodal involvement, and distant spread. Now for our delineation purpose, distant spread or metastatic spread is not important because you do not contour for metastatic stomach cancer for neoadjuvant or adjuvant treatment. Now the local extension mostly is by direct involvement to the surrounding structures, which I've already mentioned. For proximal tumors, it's important to understand that the proximal tumors around the fundus or in and around the cardia, they can actually spread upward through the esophagus. And that is why when we contour the proximal stomach, we also include lower part of the esophagus. Certain length of esophagus has to be included in the target volume. For distally located tumors, it's also common to, for the tumors to spread within the duodenum. And we'll also find that when we contour for distally located tumors, part of the duodenum is also included in within the target volume. Now, regional lymph node metastasis, as I was also already showing in the diagram, you have to know the Japanese classification system, the latest one. Now, so that was the pattern of spread. And now the pattern of failure. Why pattern of failure is also important, because we need to know where exactly we need to treat in case there is no gross tumor at the presentation. Even if in absence of any gross tumor or tumor, those are the areas where there is a high potential for the tumor to fail. So we have to include those areas in our target volume. Now, this is one of the very seminal article where the pattern of failure was shown in a very nice manner. And if we see, we can see that majority of the failures are actually locally in and around the gastric bed or anastomosis, or in the peritoneum with peritoneal seeding, the lymph nodes, or it can be a combination of local and regional. If you see, peritoneal seeding is happening in almost 42% of the cases, and distant metastasis happens in 36% of patients. So in these two scenarios, it becomes a metastatic tumor, and usually we do not give chemoradiation or definitive radiation in these scenarios. Now, another very important article, which actually describes in a very lucid way the lymph node stations at risk, depending on the location of primary tumor within the stomach. So if you see, when the tumor is located proximally, the main lymph node groups at risk, they are mediastinal and paracardial. But also this group of lymph nodes like gastric or perigastric, periduodenal, and porta hepatis, they are also at risk of tumor spread. When the tumor is located at the body of the stomach, the entire nodal site, especially perigastric in and around the stomach, is at risk. And in case of distally located tumor, it's around the antrum, duodenum, porta hepatis, and also the mediastinal group, the splenic hilum group. And this is a relatively new article where the pattern of lymph node metastasis was analyzed, and it's an extensive discussion. I cannot go into the details of each and everything, discussing what was the exact percentage of tumor spread. But if you are interested, I can share the article and you can go through it. Now, exactly when do we discuss about role of radiation in stomach cancer? This is the latest NCCN guideline, and if we go by this, role of radiation is actually not widespread, it's actually limited. So for medically fit patients, we all know that surgical dissection is the standard of care. And it's only when patient is medically fit, but there is some protocol of neoadjuvant chemoradiation, we can include the patient over there. So it's like medically fit patient, T2 or higher and node positive tumors, or medically fit but unresectable surgically, we consider for definitive chemoradiation. And here we can consider about preoperative chemoradiation. Now, as per the latest guidelines, this is not a category 1 recommendation. So category 1 recommendation is perioperative chemotherapy. Now, if a patient has not received any pre-op treatment, in that case, after a R0 resection, even role of radiation is limited for T3, T4, and node positive tumors. It can be variable chemotherapy, and if it is T2N0 or T1N0, then there is no need of radiation, and either surveillance or chemotherapy is sufficient. In case of a R1 or R2 resection in patients who have not received any pre-op treatment, either chemo or chemoradiation, there is a role of chemoradiation in this setting. So a patient who has not received neoadjuvant treatment, R0 resection, but T3, T4, or node positive, those patients merit chemoradiation, or margin positive or gross residual tumor, they merit chemoradiation. If a patient has already received pre-op chemo or chemoradiation and is coming with R0 resection, then for node positive tumors, there is role of chemotherapy. In case it's R1 or R2 resection, there is a role of chemoradiation. So essentially, and this is unresectable locally advanced, medically not fit, we can consider about chemoradiation. So that is how the role of radiation is now limited. No neoadjuvant treatment, patient underwent surgery, T3, T4, and node positive, we should consider about chemoradiation, margin positive or gross residual. Again, for patients with pre-op treatment who are margin positive or having gross residual, or unresectable. So these are mainly 3 scenarios where there is a role of radiation as part of definitive treatment. Now, palliative radiation we are not going to discuss. What are the evidences? Evidences are actually not very robust at this moment for role of radiation in stomach. You can see that 4 randomized trials of adjuvant chemoradiation and 2 with neoadjuvant chemoradiation. And that also includes a lot of significant number of patients who are actually either esophagus or esophagogastric junction. Now, this is a classic. This was one of the landmark studies, McDonald study or intergroup study, where adjuvant chemoradiation was given for T3, T4 node positive tumors. 1 cycle of adjuvant chemo followed by 2 cycles of concurrent chemo with radiation, and then another 2 cycles of chemo. In that trial, there was some overall survival improvement, but it was seen that majority of the surgeries were less than a T2 resection, and perhaps in that particular subset, radiation showed a benefit. Other studies actually failed to show a significant survival benefit. Now, POET and CROSS, So POET and CROSS, they are basically trials of neoadjuvant chemoradiation, and that include esophagogastric junction tumors. And in these two trials, CROSS actually showed survival benefit, and POET also showed a trend towards improved survival. So essentially we are limited with only 2 studies where we can see some benefit with radiation. Now, some ongoing trials are also there for locally advanced gastroesophageal junction tumor or gastric tumor. Now, all these 5 are actually neoadjuvant trials, but surprisingly, only 1 study, which is Top Gear, that includes stomach cancer patients. So others are basically either esophagus or gastroesophageal junction tumors. So pure stomach is included only in Top Gear study. So Top Gear's result is yet to be published, and we have to wait for that. Now, coming to radiation technique, how do we simulate? What are the steps? So basically, first of all, we have to select the patient properly, as we discussed about different indications for radiation. So as per that, we have to select the patient. Then we have to explain the radiation process to the patient, position the patient, immobilize, do a simulation scan, and delineation, planning, evaluation, execution. So that is how the flow works. Now, many of the centers may not be equipped with all these fancy gadgets like body fix or backlog with respiratory motion management system. However, this looks pretty decent with relatively easily available things like you have a knee rest, you have an ankle rest, you have head rest, a shoulder rest, and you use a thermoplastic mold. So this is quite easy to have and easy to do. So general guidelines about radiation, you need to know how you will prepare the patient, and on the day of simulation, how you instruct the patient. So it's preferable that when you are treating for neoadjuvant treatment, the stomach is intact. We want the stomach volume to be as minimum as possible to avoid significant dose of radiation to surrounding structure. The stomach has to be empty, and the patient has to come with 3-hour fasting stomach, and should not have a heavy meal in last 3 hours or in a fasting state. We also prefer to give IV contrast and oral contrast for proper delineation of blood vessels, to see the blood vessels properly, to see any enhancing tumor, and to see the bowels proper, the duodenum, the jejunal lobes properly, because they all come very close to the stomach. 4D CT planning, if available, definitely it's excellent to have, but it's not mandatory. Without 4D CT also, without respiratory motion management also, proper radiation can be planned and delivered if you have adequate understanding of the concept of ITV. Now, a bit about the 2D conventional planning, because many centers who are practicing radiation for stomach cancer even now actually are forced to do a 2D planning because of lack of availability of facilities. So that is how the landmarks, the borders, superior border, inferior border, left lateral, right lateral borders are decided. It's very important to go to the diagnostic CT scan when you are planning with 2D technique, because with the CT scan, you can actually find the location of the tumor, and you can actually have an understanding and relation and distance from the borders of vertebra on the imaging. You can calculate how much is the distance from lateral border of the vertebra for splenic hilar region, or at exactly what level you are finding the celiac artery, or you are finding the porta hepatis. What is the distance of that? So you can actually calculate all these things from a diagnostic CT scan, and that will be definitely helpful in proper planning, even when you are doing it with 2D technique. Now, this is again from that landmark article by Smalley, where they have typically shown 3 practical scenarios of stomach cancer. One antral cancer, so two antral cancers and one gastroesophageal junction and cardiac tumors, they have actually demonstrated how 2D planning have to be done. So all the information from diagnostic scan was basically incorporated in the simulation field. We take a simulation film on the treatment on the simulation couch, and you interpolate all the organ information, the normal organ anatomy, based on the vertebral level or other available information. And then you decide which areas to be blocked, which areas to be included. Sometimes you can also find surgical clips, like here they have shown the staples which are visible. The remaining stomach sometimes can be visible for a distally located tumors. If there is a partial gastrectomy, you can see it on simulation with barium swallow. However, for proximally located tumors, or when total gastrectomy is performed, it may not be seen, and in that case you will actually find the anastomosis at a higher place. Again, the anastomosis can be appreciated on a on-table contrast simulation. So interpolate all the information from diagnostic scan on the simulation X-ray, and then decide about the treatment volume. And this is how you actually come to know about various information. You can see this anastomotic region, and this is how basically the authors have interpreted the information and actually drawn the duodenum. Now, coming to conformal radiation planning or delineation-based planning. So all diagnostic informations has to be there to accurately understand where the tumor was, so that you can actually decide which nodal stations you will include in the treatment planning. So when it is a proximal 1/3 or fundus or cardia or gastroesophageal junction tumor, the proximal lesion, and you have to give around 3 to 5 centimeter margin of the distal esophagus. So that is what I was telling at the beginning, that around 4 to 5 centimeter of distal esophagus comes in the target volume when you treat the proximal stomach. Similarly, around 3 to 5 centimeter margin of duodenum or duodenal stump has to be included within the target volume. Now, what is a duodenal stump? There is another term which is anastomosis. So if you remember from the basic surgical principles, the initial days, it was like Billroth 1 and Billroth 2. One was direct end-to-end anastomosis between the remaining stomach and the duodenum, cut end of duodenum and cut end of remaining stomach, and it was an end-to-end anastomosis. The other kind of anastomosis was when the jejunal loop was pulled up and the side of the jejunal loop was anastomosed with end of the stomach. So it's kind of end side and end on side anastomosis. So and this was known as Billroth 2. So in this type of surgery, when Billroth 2 surgery was performed, you always get a remaining part of duodenum. So that, just imagine that there is a cut end of stomach and the junction of stomach with duodenum. So what happens to the remaining duodenum? Because the anastomosis happens with stomach, not with the duodenum in Billroth 2. So the remaining duodenum basically are obliterated by the surgeon. And because of the peristaltic flow, the content of stomach should usually not go to the duodenum. So it's when we do a contrast scan with oral contrast, the duodenal stump may not be visible because of the proper peristaltic movement. However, if there is a retroperistalsis, you can actually see the duodenal stump also. So that is what duodenal stump is. Important to understand what is a duodenal stump. And if you see what are the nodal areas at risk for proximal tumors, is perigastric, celiac, left gastric, splenic hilar, hepatic, portohepatis, and also the level 1 and station 1 and 2, or the the right and left paracardial lymph nodes. For middle is the entire perigastric, celiac, left gastric, splenic artery, splenic hilar, hepatic, portohepatis, suprapyloric, subpyloric, pancreaticoduodenal. So it's a huge volume of nodes. Again, for distal third, the nodes are perigastric, left gastric, celiac, hepatic, portohepatis, suprapyloric, subpyloric, pancreaticoduodenal. a summary of site of tumor and the nodal stations we need to include. So because this presentation will be shared with all of you, so I am not actually going into the details. You can go through this later on. This is how the organ tolerance or dose constants are given. Again, you can go to any standard guideline. So this is from NCCN 2021. Also, there are other guidelines like you can follow the Quantec or you can follow Timmerman. Which one is you want to follow, you can, but just follow anyone consistently. Now, let us now come to the specific neoadjuvant and adjuvant part. So for neoadjuvant and definitive radiation treatment, we can actually see the gross tumor within the stomach or gross nodal disease on a scan. It may be diagnostic CT scan or it may be a diagnostic staging PET CT scan. So we have gross tumor within the stomach and we have gross tumor or the gross tumor of the node. So a GTV primary stomach and GTV or GTV tumor and GTV nodes. So we have two separate GTVs and then we have two separate CTVs, a primary CTV and a nodal CTV. So the primary CTV in case of definitive radiation should include approximately 5 centimeter all around margin within around the tumor within the stomach. So 5 centimeter all around within the stomach, and then if it is a fundus tumor, then we have to include the if it is a proximal tumor, then we have to include the lower part of the esophagus also. And if it is a distal one, then we have to include the proximal part of the duodenum also. Now, why 5 centimeters? Because that includes most of the, because it coming from surgical series and autopsy series, it was found that majority of the tumors this way are actually included when you give 5 centimeter margin around the tumor within the stomach. So it's like you are including the entire mucosal surface of the stomach and stomach wall with a 5 centimeter margin. Now, the nodal CTV, as per the location of the tumor, as I said, it may require inclusion of level 4, station 14 and 16, which are very lower down around inferior mesenteric artery vein and the bifurcation of aorta. So if it is a distally located tumor, you need to include these stations. Now, regardless of the location, a 5 centimeter in all direction, that becomes the CTV. Now, centers who are practicing respiratory motion management can create an ITV, and there is some guideline about ITV in absence of 4DCT also. So we give 1 centimeter margin all around and 1.5 centimeter margin distally around the CTV. So that forms the ITV. Now, we all know that ITV is basically to include motions due to respiration and internal organ filling. So approximately that much margin makes a decent ITV even in absence of 4D CT scan. A very important article which was published in 2009 by this URTC group about the nodal stations, depending on which part of stomach or esophagus is involved. So it's basically for GE junction and stomach. So it describes how the elective nodal groups should be included. So this is for the proximal stomach. You can see that for proximal stomach, the nodal groups are mainly in and around the proximal part and the body. And in any case, we need to include this perigastric group of lymph nodes. Now, for neoadjuvant treatment, we may not always need to include the entire stomach in our primary CTV because we give 5 centimeter margin and that should be adequate, but we have to edit it. We have to edit that margin according to the mucosal surface of the stomach. So it should not go beyond stomach and involve other surrounding organs because 5 centimeter margin all around is a huge margin. So if we say, for example, there is a tumor over here and we are giving a 5 centimeter margin all around, so it will come to diaphragm, it will come to spleen, it can also come down to adrenal. Definitely, in absence of gross extension to these organs, it may not be necessary to include those organs. So we have to strictly be confined within the stomach wall in absence of any direct infiltration of the organ. So that is how the lymph node stations look like when there is a tumor in the middle or body of the stomach. And that is how it looks like when it's a distally located tumor. Now, for adjuvant treatment, a lot of articles are there. You can go through all of them. That is how the delineation, the principle of delineation works. You identify the gross tumor, any residual tumor on imaging. It's always important that if you have a facility to fuse the diagnostic image, then it's best to fuse the diagnostic image or preoperative image with the planning CT scan to have an idea where the tumor was located. That will always give you a very good idea about tumor bed, and chance of missing the tumor will be less. So the gross tumors, in case there is a gross tumor, the gross tumor can be boosted again with an additional dose of 50.4 to 54 gray. So standard dose for stomach tumor adjuvant treatment of stomach cancer is 45 gray in 25 fractions. However, for residual tumor, if there is a gross residual, then or there is R2 resection, so that area has to be identified and needs to be given additional dose, which can be around 50.4 to 54 gray depending on the organ tolerance and achievement. And then you need to give margin around that CTV to create the PTV. One important thing is to have the ability to identify the hepatogastric ligament, which is basically something which lies around the lesser curvature, in between lesser curvature of the stomach and liver. So let me just show this. So here you can see, so I'm just showing this. This is the lesser curvature and this is the liver. So the omentum is actually extends from this medial border or from this surface of the lesser curvature to the liver, which is known as gastrohepatic ligament. So what happens many times, the nodes are not dissected from that area because of difficult location, and this area always needs to be included in the target volume. Now, duodenal stump anastomosis, as I was saying, that it needs to be included. Now, when just imagine that there is a tumor located at the G junction or cardia or fundus of the stomach, then that's definitely far away from duodenum, and there is hardly any chance that the microscopic tumor from that primary tumor would reach duodenum. So do we need to include duodenal stump in that case? No, we do not. So for a proximally located tumor, we do not need to include the duodenal stump in our primary CTV. However, if the tumor is located in distal part of the stomach or antrum, then definitely duodenum is a very nearby structure, and there can be submucosal spread of tumor from antrum or pyloric region to duodenum. So in that case, the duodenal stump has to be included in the target volume. Now, as I was saying that it sometimes becomes difficult to identify the duodenal stump, because even if you give oral contrast, it will not go to the duodenal stump because of the peristaltic movement. So you can take help from the radiologist about how to diagnose or how to detect this duodenal stump. Now, gastrojejunal anastomosis. So there are two different types of anastomosis which can happen. One where the stomach is remnant of the stomach is there. So for a distally located tumor, the proximal stomach can be saved and it can be anastomosed with jejunum. In case of body or proximally located tumor, the entire stomach needs to be removed, where you get only esophagus, and then the esophagus is anastomosed with jejunum. So that becomes esophago-jejunal anastomosis, or it can be a gastrojejunal anastomosis. Now, identifying that anastomotic site is important because that has to be included and treated in all cancers. Now, para-aortic nodes, if you need to include this because of a distally located tumor, then the entire length of or entire chain of para-aortic lymph nodes throughout the CTV. So wherever the CTV is present, para-aortic lymph nodes has to be included. Now, So you can see this is how the gastrojejunal anastomosis looks like. You can see the contrast. Because the contrast goes to jejunum, so we can identify this with oral contrast on table. The duodenal stump in this patient is visible, but it may not be visible in all patients. So you can see here the remnant of the stool is a post-op patient. Distally located tumor, so the remaining stomach we can see here. So remaining stomach, the anastomosis. And here you can see the hepatogastric ligament. We can see this better in another image. Again, for body or mid-third of the stomach, this is the recommendation. You can go through this. With different stage, primary and nodes, there are different recommendations of how much you need to include. But for mid-third or body, you can see that you always need to include the remaining of the stomach. There is no confusion about that. So adjuvant treatment, the remaining stomach, wherever it is present, has to be included in the target volume. And the nodal volume, you can follow the recent guidelines. It's a kind of old guidelines, but you can follow the recent guidelines. For GE junction tumors, as you all know from the delineation principle of cross study, you know that 3 to 5 centimeter margin of esophagus has to be included. And the residual stomach or anastomosis has to be included. Now, I think I've already discussed this. This is how the nodal volume looks like in case of a proximal tumor. Middle 1/3 and this is distal 1/3. That is how a post-op image looks like in case of stomach cancer. So if you have a good understanding of the vessels, then you can actually realize that the celiac artery, then suprapyloric, group 6 is infrapyloric, so it is here. This will become much more easier if you have a software which can fuse your the pre-op CT scan with the post-op image. So that will help you identifying where the supraduodenal, infraduodenal, all these groups of lymph nodes are present. Now, group 8 is basically common hepatic group. So if you can identify the artery, you can also identify the lymph node station. This is the portal hepatis, group station 12. You need to include this entire remaining space, which we call gastric bed. So a little bit anatomical understanding of what gastric bed is and what are the boundaries. I forgot there was some very interesting mnemonic in our MBBS days. I really forgot that, but it's like left cross of diaphragm, then you have spleen, then you have left adrenal, then you have left kidney, then you have pancreas, then you have vertebral body, then on right side you have the porta hepatis or liver. So that is how, and in front you have the transverse colon. So jumping a little bit. So it's interesting that all these lymph nodes are actually located around the blood vessel, but when you contour, you can make a little bit simplistic way if you have the idea of stomach bed. So here you can see that this is the colon and the contour goes actually, it includes an area between the colon, the splenic flexor. You don't go to the perinephric fat, you come straight away to the anterior aspect of the vertebral body. And then you include part of the, you include this gastrohepatic ligament and you include the portal region and maybe 1 or 2 millimeter of liver over here. And as you go down for distally located tumor, you actually contour the entire pancreatic body or pancreatic head of pancreas, the body of pancreas or tail of pancreas, depending on which group of lymph node you want to include, because it's literally not possible to spare the pancreas and treat the supraduodenal, retropancreatic, all these group of lymph nodes. So if you see even here, the entire pancreatic head, the body, and even the tail that was included in the target location. Now, there will be So this article actually discusses very nicely about how to contour the gastric these lymph nodes. Now you can practice this for intact stomach patients, and this color coding shows which group of or which station of lymph node is this and how to contour this. So you can see this left paracardial group. This green one is right paracardial, then this turquoise blue. This is around the greater curvature. This is the splenic hilar group. And gradually, as you go down, you include this lymph node around the lesser curvature. Then again, you contour the hepatoduodenal group or the lymph nodes along the gastrohepatic ligaments. You include the para-aortic group of lymph nodes. So now this was for a normal stomach. Now this is a scan where the stomach is resected and we do not have the stomach, but then we can see we can see the arterial relationship, and we can identify the lymph node groups. Now for such patients, then the way forward or the way of the solution is to have a proper fusion, while you can see the preoperative tumor and its relationship in respect to the current scan. Now these are different organs which we contour for stomach radiation: large bowel, duodenum, in case it is present. So in adjuvant setting, you may not be able to find this duodenum. If yes, then you contour that. And for neoadjuvant setting, try to save duodenum when it is not indicated to be included in the target volume. Different other important organs are liver, kidney, which is one of the most important organs which you need to save while you radiate for stomach cancer. And then we have the small bowel loops, and we have large bowel. Now here is an example of a clinical T2, clinical N2, M0 G junction tumor. So the esophagus has to be included, and in and around that we need to include the para-aortic group. So this esophagus, as I was telling, that almost 5 centimeters of esophagus has to be included in its length. You include the stomach, 5 centimeter margin around the gross tumor, and then as you gradually keep on contouring, you can see that you basically include the entire stomach, the perigastric lymph nodes. So this is the border of liver, and this is the stomach, and in between you can now see the small structure. This is gastrohepatic ligament, and you can and if you implant this distal part or pylorus when it's a distal located tumor, gradually as we go down, we will find that this, the head of pancreas, the body of pancreas is also coming within the target volume. And gradually do this splenic hilum, and you can here follow the splenic vein and splenic artery. The vein remains anterior and the artery remains posterior, and it's important to scroll up and down in a planning CT scan to understand which one is artery and which one is vein. But practically, what we include actually the entire body of pancreas and the space in between the spleen or the splenic hilum, perinephric fat, anterior vertebral body. Then we go to the porta. We include or exclude duodenum depending on the location, and the same way it is being done. Now, depending on the primary tumor location, if we need to include lymph node group, down either till the bifurcation of the aorta. So I end here, and any question? And
Thank you, sir. Participants can ask their queries in chat box. Thank you.
So there are some questions. Voice not clear, voice not clear. I'm sorry if there is some disturbance because of the internet connectivity.
That was not now. Like it was during the starting session.
So Dr. Avi has asked about do you use oral contrast or negative contrast along with IV contrast in case of NSCTRD? So I always prefer to have a proper oral contrast in small amount. I don't want to give a lot of water for drinking in case of stomach cancer because that increases the volume of the stomach. Consequently, it increases the dose surrounding organs. So an empty stomach but a small amount of oral contrast is very helpful. It has to be very diluted, should not be a high contrast scan because that will create a lot of artifacts. So oral gastrographin, or for centers where you do not have access to gastrographin, you can just use 1 or 2 ml of diagnostics iodinated contrast in approximately 1 liter of water. So that will give a good contrast, which will not cause artifacts. For CCRT, which chemotherapy is used or prefer and dose? So although it's not actually to discuss about the management of stomach cancer, it depends on which center you are working. Now, most of the centers nowadays are actually not practicing chemoradiation or neoadjuvant setting. Most of the medical oncologists are now actually practicing neoadjuvant or perioperative chemotherapy. And in case you are willing to participate in a trial, or if your center is practicing neoadjuvant chemoradiation, then the options are practical options are concurrent 5-FU or capecitabine. Can you elaborate vessel's anatomy on CT scan to identify the vessel? Okay, so Dr. Vaibhav, I think last year's tumor target volume delineation class have uploaded the videos. You will have the vascular anatomy in that class. And I can actually show it once again. For easy understanding, I always refer this particular image. This is a very good schematic diagram to understand how the blood vessels are situated. Now, this is the celiac trunk. Now, celiac trunk gives rise to 3 arterial branches: the left gastric, splenic, and common hepatic. Now, how to identify this celiac axis? On a contrast scan, you follow the aorta. The first anterior branch of aorta is celiac axis. The direction of celiac axis is a bit unusual. First of all, it goes a little bit upwards and then it goes down. So it might happen that the distal part of the celiac axis are visualized on a in the earlier part of the scan or in the superior part of the CT scan. Now, once you identify the first anterior branch originating from the aorta, you track that, go up and then go down. So that will help you in identifying celiac artery. Now, it's not so easy to identify blood vessels. For the beginner, it needs some study. You need to go through multiple scans. You need to see how, you need to sit with the radiologist. And then definitely after 5 or 10 scans, you will be able to realize how the vessels look like. Now, the baseline or the starting point to identify all these vessels are celiac axis. The first one is celiac axis. You can identify these vessels after that. So splenic artery, usually it runs behind the pancreas, and vein is usually anterior to splenic artery. If you are unable to identify this, you can do it in a retrograde manner, identify the splenic hilum and start identifying which are the vessels, and gradually you go up or down to know where is it going. Now, common hepatic artery, which is a third branch of celiac axis, it has 2 main divisions: hepatic artery proper and the gastroduodenal. Now, hepatic artery proper, it gives the first branch, which is known as right gastric. So this is the right gastric artery. It comes over the supraduodenal part and gives it branches. Now, if you see, there are two different venous arcades or arterial arcades. One is around, sorry, no, it's not venous, it's arterial arcades. One around the lesser curvature, the other one is around the greater curvature. This lesser curvature artery is formed by branches of this left gastric artery. So it gives its branches over here. If you see the new Japanese classification, the lymph node stations are actually based on this. So this group 3, they're actually around the branches of this left gastric artery. And then this right gastric artery also gives it multiple branches around the lesser curvature and they form the arcade. So right gastric artery is the first twig of the hepatic artery proper, and after that it continues and then it ends by branching into 3. The first one is cystic artery. Again, it continues and then gives right and left hepatic artery. So this is right hepatic artery, this is left hepatic artery, this is cystic artery, this is hepatic artery proper, this is right gastric artery. From celiac axis directly left gastric artery and it starts giving its branches. Splenic artery, it travels towards left. It's a long branch, it's a long artery, and it enters the spleen. So it becomes relatively easy to identify splenic artery. And the second branch of this common hepatic artery is gastroduodenal. So from the name itself, you can understand that it will have its relationship with stomach and duodenum. So one branch, it goes, so it continues and gives a branch with known as superior pancreatico-duodenal artery. And the other one, it continues along the greater curvature, known as right gastroepiploic artery. Splenic artery, it divides into short gastric artery and the left gastroepiploic artery. So this left gastroepiploic artery and right gastroepiploic artery, they form the greater curvature arterial arcade. The next question, thank you, Dr. Debanjan. Dr. Ravi, criteria for patient selection for NACTRT. Now it becomes very difficult. To be very honest, Dr. Ravi, nowadays it becomes very difficult to have patients upfront who comes to me for decision making. Practically, we get patients who are already treated by the surgeon or medical oncologist. So decision making for NACTRT is practically difficult. All patients practically go for perioperative or neoadjuvant chemotherapy. Only when it remains inoperable, even after that, we get to be involved. Now, the criteria for NACTRT in today's time is a bit sketchy because most of the data are actually now for perioperative chemotherapy. So tumors which are in and around the GE junction, I would probably go for neoadjuvant chemoradiation. But if it is adeno, then you have equally good result with chemotherapy itself. So surgeons who do not want to have a fibrosed operating bed, they really do not prefer radiation before surgery, so they prefer chemotherapy. So if you ask me which are the group of patients for which I would pitch for neoadjuvant chemoradiation, then yes, it's mainly for GE junction tumors or proximally located tumors. For advanced stage, which palliative chemo is preferred? I am really not an expert on chemotherapy. I am really sorry, but what I know is mainly 5-FU based chemotherapy. So it can be 5-FU or it can be capecitabine. It can be, if the patient's performance status is very good, then you can add platinum, taxane, roll of HER2, yes, for metastatic cancer if it is a HER2 expressing tumor. But again, I am sorry, I do not practice chemotherapy. So my role on my knowledge on chemotherapy is really very limited. But yes, you can test for HER2 in case of a metastatic disease, and if it is HER2 positive, then you can add anti-HER2 treatment, which has some survival benefit also. Okay, so I think there are no more questions.
Sir, one more is there. Regarding inclusion of head of pancreas, any recommendations they have asked?
So you see, if you talk about head of pancreas, then you need to know which group of lymph node is it. So again, I have to go to the same diagram. Okay, so station 13, if you see, so that is the station which actually is situated behind the head of pancreas, and this station is included for distally located tumors. So distally located tumors, antral tumors, pyloric tumors, or tumor involving stomach and duodenum, you need to include this, and in that case, you have to include this. So if you see, so this is station 13, which is, so if you think about a coronal section, the it's in between vertebral body and the pancreas. Now, practically when you contour, it's really not possible to contour the duodenum, the stomach, leave part of the head of pancreas and radiate the retropancreatic node. So for all practical purpose, you actually need to include the entire portion. If you see this image, let me show this. Okay, so here you can see this is the station 13, and you need to include this entire area. Now, is it literally possible to spare head of pancreas and treat this 13? It's not, because even if you spare, even if you don't contour this in your CTV, the moment you give a PTV expansion, this entire region comes within your PTV. So for distally located tumors, when you need to treat station 13, head of pancreas will come in the target volume. How much nodal expansion is to be given? It's around 5 millimeter to 1 centimeter. What motion control do I use routinely? Usually, I do not use any motion control. I treat with free breathing, create some kind of ITV. I have told you that how to create an ITV even when you do not have a motion management technique. You give 1 centimeter expansion all around and 1.5 centimeter distally. During radiation, Ryle's tube insertion is necessary? No, if the patient is able to take food properly, it's not required, but it's required for, sometimes it's required for esophagus or G junction tumors if there is a blockage. Now, let us consider that it's a stomach, it's a gastric cancer, and the patient is unable to eat properly because of the tumor. Then putting a nasogastric tube will not help. It's always better than, in that case, you plan for a direct enteral feeding with like percutaneous feeding tube into jejunum or something like that would be much better. For G junction tumors or esophagus cancer, guided Ryle's tube can be placed if there is almost complete blockage of the lumen. If the lumen is not completely blocked, Ryle's tube can be put simply on OPD basis also. Okay, so any other question? I think there are no more questions.
Yes, I think it's done. I request Dr. Jagdish and Additional Professor RCC Jipmar to deliver out of thanks.
Dr.
Hi, sir. Good evening.
Hi.
Nice to see you after a long time.
Thank you. Thank you. We all are very deeply obliged and honored to have you in this podium. And it has been always a pleasure for us to have your presentation in Jipmar.
So it's a pleasure. It's a pleasure for me to be here, and it's a great academic institute with a lot of great people, and it's a real honor for me to be here.
Yeah,
The honor is all mine.
nice. For that. And, you have done a wonderful presentation detailing each and every part of the stomach very patiently. And I think all of our listeners and participants would have benefited from your presentation.
I must show this one slide, and I am deeply obliged to all these. So my sincere thanks to all of you. Definitely my patients on whom I contour the guidelines, my resident Dr. Neelam, who has a lot of who has done a lot of job for this presentation and a lot of information from Google and Arrow case series. So I'd also request all of you to go through all this, and in case you need articles or anything related to this, I'll be more than happy to share.
Thank you. Thank you for your word.
Thank you so much. Thank you so much.
And we are happy and we hope you will continue. Is it echoing? I think it's going. Okay. So we hope you will help us and joining in future lectures as well. I know there is a lot of webinar series going on, pressure, with huge pressure on multiple people. So
it will always be a pleasure, sir. It will always be a pleasure.
Thank you. Thank you